Lagos television, and today we have an issue that concerns women. It's a very important topic, reducing maternal mortality in Lagos, and we have Dr. Funmi Ige. She's the president, Medical Women's Association of Nigeria, Lagos State branch. Yeah, she will be talking about why our mothers are still dying while giving life and what is being done to reverse this trend. These and many more will be discussed right now. You're welcome.
Thank you very much. Thank you for having me.
I'd like you to tell us the current state of maternal mortality in Lagos right now.
All right. So maternal mortality is rate is the number of women that die from pregnancy and birth-related conditions, and it's usually measured per 100,000 live births. In other words, if you get 100,000 women who give birth, how many die per annum? That's how that rate came about. Okay. Globally, the figure is 197 women per 100,000 live births. And in Nigeria, the figure is quite serious and of concern, 993. You can see that compared to the global figure, 197. Yes, is that in Nigeria. So coming back to Lagos, yeah. We have, out of this figure, 430 maternal deaths per 100,000 live births.
430.
Yes.
So that's to tell you. The years, is it getting better? Is there any improvement?
There's a little improvement, but it's just marginal.
Okay.
In the last 23 years, this national figure has only reduced by about 30% from over 1,000 to 993. It's not significant, but then it's something. If we keep at it and improve on whatever it is we've been doing, the figures can be better. That figure of 993 is the highest in the world. That's the figure as at 2023 in Nigeria. You can see it's serious and it's cause for concern.
Okay, let's get to know what are these direct causes of the maternal mortality here in Lagos.
Okay, so there are a number of causes. We have what we call direct causes and indirect causes, and there are other contributory factors. Of the direct causes are those causes that have to do with the health of the woman, and top among the list is what we call hemorrhage, bleeding. Women bleeding in the period before pregnancy. Yes, excessive bleeding.
After birth?
During and after birth.
Oh, during and after?
Yes. Okay. Well, we call that postpartum hemorrhage. That's hemorrhage resulting immediately after delivery. The delivery could be spontaneous vaginal delivery. It could be by surgical intervention. That's our cesarean section that we popularly call CS.
Yes, yeah.
So whichever it is, hemorrhage is hemorrhage. A woman bleeds in the immediate post-delivery period. That's one of the leading causes of maternal deaths. And then the woman could also die from infection during pregnancy, infection in the immediate delivery period up to...
Is that the one they call sepsis?
That is what we call sepsis. Okay. I'm trying not to use too many
medical words.
Yes. Yeah. So that's infection, that's sepsis. And then they could also die from hypertension-related diseases, that is things having to do with their blood pressure. You could have a woman who ordinarily is not hypertensive, and then she gets pregnant and her BP starts going up, and then she has to be monitored well. If not, it goes up and then it gets to an uncontrollable state and she throws a fit, which we call eclampsia, and then that could also lead to her death. So that's another cause. Yet another cause is unsafe abortion. Young ladies, some married women, for some reason they don't want it to retain the pregnancy they have, and they want to terminate that pregnancy. If it is not properly done at the right place, that's the one we call unsafe abortion. It could also lead to their death. And then we have what we call obstructed labor. This woman is pregnant, she has come to time to deliver, and for some reason, the birth is not going as expected. There's something obstructing the baby, maybe the narrowing of the birth canal, or there's a disproportion of the size of the baby's head to the woman's birth canal, and then that delivery is obstructed. That also, if not well handled, can also result in the death of mothers. So these are the major and leading direct causes of maternal deaths in Lagos.
Some have also, linked this traditional birth attendants also, because we have more women, going for to the TBAs instead of coming for health care services in our hospitals. Some have also linked the TBAs to maternal mortality. What is your take on that?
Yes, they are part of the contributory factors that I mentioned earlier on. I did say there are direct causes, there are indirect causes, and then there are contributory factors. So I'll group the TBAs under the contributory factors. Now they have a group of permit me to use practitioners that have come to stay in Lagos State. We cannot deny that they are there. Our people patronize them. So many of them do not know their limits. By limits, I mean where we cannot continue. We have to draw the line that this one is beyond us at this place. So this person needs to move to a more formal setting, either the secondary healthcare facility or the tertiary, as the case may be. So because of that, they are also a huge contributory factor to maternal deaths.
Why do women prefer going there?
Well, that also brings us to some of the indirect causes. Socioeconomic factors, cultural beliefs, poverty, lack of economic power, problem of access. If you live far from where a good healthcare service provider is, you want to go to one that's nearest to you. And you will observe that these TBAs are almost everywhere in the community, especially in those underserved areas where access is a problem, bad roads, bad road networks and things like that. So that's why some people go to them. Some, due to their cultural beliefs, they feel more comfortable going to them because they have some cultural things they do, traditional, maybe herbs and other things they give to them. So that makes some people prefer going to them.
Okay, since now that we know that more women like to go to them, I know that the Lagos State government is trying to integrate them into the formal health sector. How much do you think this will help in saving more mothers' lives?
Well, it has actually been helping because it's an ongoing thing. What the state government has attempted and have done is to train them. There was a year I think they have been made to register now, so they don't just practice anywhere. So they themselves have some control in place. They have their own regulatory bodies, so they have been made to register with the state, and then they were trained. The state organizes healthcare workers from the State Ministry of Health to train them. Training them to know where to draw the line, to know what some danger signs, what you will see and be able to say, okay, escalator, no, this one cannot stay here, has to go out. So the state government has trained them, and I'm aware there's retraining also ongoing. So that's one good thing that the state government has done, training them and retraining them. So I think that way there'll be some gains. I do not have exact figures of what has how that has helped, but I do know that it has helped. I'm aware that some of them are attached to some secondary facilities. So when they have challenges with their clients, they refer the clients to the nearest secondary facility close to them.
Okay, I'd like you to talk about other efforts of the state government, done recently or made recently to improve maternal health outcomes.
Yes, there are quite a number, and let me add just say kudos to the state government. They have shown that they are concerned about the life of women. There's this mama-based initiative that the state government was involved in with some partners.
What does that involve?
Yes. What they tried to do was to recruit some women. I think it's like a data-based program.
Okay.
So they recruited some women, close to 8,000 of them. I think I have the figures, about 7,883 of them, approximately 8,000 of them. They recruited them in pregnancy and monitored them, monitored their registering for antenatal services, monitoring their going, keeping their appointments, using their drugs and all that. And through that, the state has been able to save about 178 women. I mean, that's as at the year ending 2024. So that's a positive one, and it's quite encouraging. That's one initiative that the government has done. And then there's this Project Aisha that was done in collaboration with the UNFPA, the United Nations Population Agency, and Project Aisha. That's what the program was tagged. And that one also involved identifying gaps in the system when the women come to access antenatal services. So whatever gaps that are identified, their measures are implemented.
Okay, I'm trying to understand. You said when did these mothers, intended mothers, come for antenatal?
Yes, they are registered.
They're registered.
And even with those that have not even registered, when they come pregnant with pregnancy-related complaints.
Okay.
They are identified. They are monitored closely. They are under the Project Aisha program. They are monitored, and then they are responded to. Whatever it is their challenges, there's a prompt response. And the idea is that within 30 minutes to 1 hour, they must be sorted out. So there are dedicated drug stores or drug trays for them. So that it's not the time that you start writing and then the relative is running helter-skelter to go and look.
They already have the data.
Yes. Okay. There are a list of drugs. I can confidently talk about that because the facility where I work is a state facility. We are involved in the project. So when they come in as emergency, they must be attended to promptly to reduce what we call third stage delay. There are delays in a woman accessing care. So when the woman delays at her own end, that's the first stage delay. No, she has not managed to bring herself to the facility. So her time should not be wasted. There should be further delay. So that's what we call third stage delay. So we try to minimize that. So under the Project Aisha program. And then there is what was initiated last year, a whole week dedicated to maternal, newborn, child, adolescent health and nutrition. Yes, a whole week of free services for them. Unless they didn't hear about it. If you hear about it, you come that week in any part of Lagos State, the primary health care centers and the secondary facilities, health care services was given to them free. That's also another way to encourage them to come to utilize the state healthcare services and of course access quality healthcare. And then the matter of fund being a challenge is taken out of the way, at least for that week. It's something. And it is aimed that by the end of 2025, by December 2025, a good number, about 1.7 million women would have benefited from that service. So that's another one that the state government is doing. And very recently, the Medical Women Association of Nigeria,
that's
my organization, with a consortium of partners, we inaugurated champions, women we called champions, women with passion for preventing maternal deaths, that will help to be involved in advocacy, community advocacy and advocacy with government, in a program we called AIM, that is Advocacy and Implementation for Maternal, Newborn, Child Health and Nutrition and Health. So these women, these champions, Lagos State inaugurated 14 of them and a super champion. And their role is to help to engage the community, raise advocacy to them, encourage them to utilize healthcare services, let them know what is available, and also advocacy to government to to create an enabling environment for these women to access care, to also to release fund. Fund has to be pumped in.
Yes,
We keep talking about money. Yes.
I was going to come in here to find out, how accessible is maternal health care to all these riverine areas. How accessible is this healthcare services?
Okay, so those areas, the riverine and very, very rural areas, or the slum areas, will come under the underserved communities. Road networks to their place is not easy.
Which you mentioned earlier.
Yes, which I mentioned earlier. And that's a problem. A problem of access is one indirect cause of maternal mortality. Every woman that is in one of those areas goes into labor, for example, or starts bleeding in the antepartum period, or even the postpartum period. Maybe a birth attendant attends to her, and then she starts bleeding, and the person is unable to control it. What happens next? The logical thing to do is to assess a health facility, either a secondary or a tertiary. But then this woman is in one remote area, there's no transportation, maybe it's even canoe that is available, if at all, So how is she going to get to that facility where she'll be attended to alive? So those are the people that are in the underserved. So what government is trying to do, and what with some partners, is to now go to them at their community. All right, if we can't, at least for now, make rules for them.
Good for them.
Yes, these people, you have to have skilled birth attendants attended to them. So there have to be people in those communities, in their midst there, who are trained in, taking delivery or attending to pregnancy and pregnancy-related issues. So it's to take that service to them so that they too can have some form of access. That is not to say that government should renege on creating the infrastructure, road networks and all that. But we know they are trying, but we know it takes time. But while they are doing that, no woman should die while bringing forth.
Okay. There was a story of a young woman which went viral recently, about a young pregnant woman who died, who lost her life in the course of pregnancy, and, looking for a health facility for her to have a baby. So this now brings me to the issue of emergency obstetric care for pregnant women. How can maybe the government ensure that there's enough emergency obstetric care available, that is 24/7 in every LGA? Do you think that would help?
Yes, I think it will help, and it is doable. At the moment, the Lagos State government have 57 flagship primary healthcare centers. The primary healthcare center is just from the word primary, is the point of immediate, it should be the point of immediate access to any pregnant woman or anybody in the community at all. But for the purpose of our conversation, we are talking about pregnant women and women who are just giving birth and all that. So there are 57 flagship centers, and I'm aware that some of them operate 24-hour services. Yes, so it's to identify those and where they are in a particular LGA, and encourage people in that LGA to access them. Even the ones that are not operating 24 hours, go there first. And then they will do the needful, refer to the nearest one if it's something they cannot handle. So at the primary healthcare level, I would say that the Lagos State government is doing a lot in that area. Those flagship centers, those that operate 24 hours are there. And then we have the secondary healthcare facilities, the ones we popularly call general hospitals. The Lagos State has about 33 of them. Yes. And amongst those, we have centers we called MCC. You must have been hearing about MCC. So it's maternal and child care centers. Because those are dedicatedly, purposely built to accommodate maternal-related issues and child care-related issues. And Lagos State has quite a number of them in different parts of the state. So, and they also, of course, all general hospitals operate 24 hours. They are never shut down. So you can go and access care. And the facilities are also trying to up their game by ensuring that, yes, even though we are attending to emergency services, this group of women we are talking about, pregnant women and newborn and children, also there are dedicated arrangements for them, so that they don't have to wait in the queue while others who do not have pregnancy-related issues are waiting. So the state is doing that.
I want you to lend a voice, to, will I say, intending mothers or pregnant women right now. At what point should they go to the hospitals, to start their antenatal care?
Okay, so when a woman is pregnant, how do she know? She would have missed her period. By the time she missed her period and she's getting to know, she's already 6 weeks pregnant. So by the time of the first missed period,
she's already 6 weeks.
Yeah.
Really?
Yep.
Okay.
So all right. So for some, they want to just go immediately. But what is advised is at the 12th week of conception, which is about 3 months.
Okay.
In the regular calendar,
yes,
it's about 3 months. When the pregnancy is about 6 to 12 weeks, the woman can go to the hospital to see the doctor and be encouraged to register. However, I must add that if it is what we call a high-risk pregnancy, this is someone who maybe perhaps has taken a while waiting before she got pregnant, or she has been getting pregnant, has been having miscarriages. Now she doesn't want to wait that time.
Okay.
So immediately she misses her period, she goes to the hospital, and once pregnancy is confirmed, she's encouraged to register. So she does that kind of a woman does not have to wait till the pregnancy is 6 months. I mean, it's 3 months.
I want you to shed more light on high-risk pregnancies.
Okay.
What are the factors?
Okay,
there, so before you now consider the pregnancy being high risk.
Okay, so advanced maternal age, no particular order, advanced maternal age, a woman is up to 35 years and above before she gets pregnant for the first time.
Okay.
She's not the kind of one to joke or play with her pregnancy.
Okay.
So she should assess medical care as soon as possible. Okay, that's one. Or a woman that has been having recurrent abortions or recurrent miscarriages. I mean, she gets pregnant and then before she knows it, she bleeds and then the pregnancy is no more. It has happened maybe 2 or 3 times. Okay, so anytime she now gets pregnant, or she doesn't want the same thing to happen again, so she goes immediately to be checked, and then there are things that we've done for her to ensure that that particular pregnancy does not go the way the others have gone. Then the woman with a comorbidity, what do I mean by comorbidity? She's a known hypertensive, she's a known diabetic, has blood sugar issues, maybe she has some other cardiac issues, she's a known asthmatic. So in other words, she has something that she's treating or that she's suffering from aside not getting pregnant. So a woman that gets pregnant in any of those states or condition should immediately go to the hospital to be assessed and taken care of. So she can't afford to wait and take her time to come at any time. So those are the kind of things I mean by high risk. Yes.
Okay. Postpartum also is when you have after you have your baby, right? Postpartum.
Yes, postpartum.
There are also some causes, postpartum that also leads to maternal mortality. What are these causes?
Number 1, hemorrhage, bleeding. And it's a serious cause for concern because it's the leading cause of maternal death and it's preventable. It's treatable, provided that something is done promptly. So most times, some of these women, they claim to have to deliver at home, or they deliver with a TBA that we talked about the other time, who has not known where to draw the line. And then this bleeding is usually torrential. It's not just sipping kind of bleeding. So something has to be done soon. When the bleeding is above 500 mils, 500 mils, let me give you a picture. We all know the pure water bag of water we drink. That quantity is 500 mils of of blood. So by the time a woman loses that from a spontaneous vaginal delivery, it is significant. You don't want to ignore it. And you want to ensure that it does not exceed that. So once that happens, the midwife or whoever is attending wants to take necessary measures.
Okay.
Now, if that woman has to undergo a cesarean session, and from the cesarean session, she's now losing up to a liter, twice a bag of pure water. Now, that's cause for concern. That's postpartum hemorrhage. It could be primary, occurring within the first 24 hours of delivery, or secondary, occurring even after 24 hours of delivery, from the second day, and then she just starts bleeding. Yoruba, they say, no, better. Yeah. It could be that bad.
Wow.
It could be that bad. So that's a leading cause of maternal death, and it's of serious concern to us in M1. In M1, that's part of why we're in this partnership with this consortium of partners to address that matter. That something has to be done. The healthcare workers have been trained; they know what to do. You know, from massaging the uterus, giving the necessary fluids, necessary injection, and escalating it. Very important. Escalating it by, in other words, calling for help, calling for a senior person or somebody or more hands to join you, so that something, because otherwise within a few minutes, if nothing is done adequately and correctly, that life can go.
Okay, what about if the postpartum maternal mortality has even nothing to do with bleeding? You know, I've had a case where a young lady who had her first child, and she had left the hospital, and it was just a few days to the naming ceremony, and then she just collapsed, and she wasn't bleeding.
Well, a lot of things could have been responsible for that. Are we sure she wasn't bleeding? Could she have had an infection, this sepsis we are talking about? Could she have had it? Could her blood level be low? Maybe if she was not bleeding actively. That is the bleeding that you can see at that time. At the time of delivery, she might have lost quite a large volume of blood. Even after delivery, women still bleed. We know if we call that locia. There's still some bleeding still come, for which they use pads and all that. What is the quantity she was losing? You know, and all that. So if she had lost so much, and she becomes pale and anemic, that's low blood volume, that could make her faint. And maybe perhaps she wasn't complaining. She wasn't telling anybody anything. She must have been feeling dizzy or something, and then all of a sudden she goes down. That is also a possibility.
Okay. So are you saying all maternal mortality could have been prevented?
Well, nothing is absolute, so I will not say all.
Okay.
But a good number,
could have been prevented.
A high percentage is preventable. And that is why I believe we are having this discussion. Yes. Okay. Something can be done to reduce it to the belly. When it comes to death, and maternal death for that matter, one is too many. Yes.
One is too many.
Yes, because that one is somebody's wife, is somebody's mother, is somebody's sister, is somebody's aunt, is somebody's cousin, is somebody's friend, is somebody's colleague. No, seriously, one is too many when it comes to maternal death. So while we cannot absolutely say that all are preventable, a large percentage is preventable. And how do we prevent it? One, education, information, awareness. Women should know that when I'm pregnant, I don't just sit at home. When I'm pregnant and even if after I have registered and I have complaints, I don't manage myself. You go to the hospital and then you go to the right place where there are qualified, skilled and trained health personnel to attend to you. You don't visit quacks. If you choose to go to a TBA, then let there be the limit. Let the TBA know. So
time is fast spent. Thank you, Dr. Funmi Ige, President, Medical Women's Association of Nigeria, Lagos State Branch, and she has shared a lot of insight into reducing maternal mortality here rate in Lagos. Thank you very much for joining us. And to our viewers, let's all remember, one thing, that every woman deserves a safe pregnancy, and one maternal mortality is one to many. One is too many. Thank you very much once again.
Thank you for
We'll go on a
having me.
short break. When we come back, the conversation continues.
Day I was robbed at some point. It was inside a shop. All these Okada riders with all these Okada guys that robbed. They came pretending to buy drug from a pharmacy, my neighbor's pharmacy shop that was sitting on, only for us to that okay. The woman tried to attend to them. Next thing they brought out gun. We are robbers. Oh yeah, your phones. We knelt down. The people we are moving around though, they thought that they were pastors that came to pray, that we were praying. They didn't know that we were being robbed. So all the people that plugged their phone in that woman's shop, they took everything. That experience. Till they left us and entered bike and moved us. People around didn't know that we are being robbed. It was such a bitter experience. I can't forget that. That was my first day of seeing gun, life and direct.
Let the conversation continue.
Still a conversation, and thank you for staying with us. You've heard it all, mothers, fathers, intending mothers. You've heard it all. We just need to take the necessary steps to ensure that we reduce maternal mortality rate here in Lagos and, of course, Nigeria as a whole. Abimbola, as a mother, what advice do you have for new mothers?
Well, religion plays a different role, and medicals play a huge role, because sometimes a lot of people just Ọlọ́run á ṣe. No be everything. Not be everything. Ọlọ́run á ṣe. Do the needful. Even if you cannot go to the big hospitals, even if it is the health center, ensure that you follow all the routines. Take just precautions. They go a long way, because like ignorance isn't acceptable under the law, so is ignorance not acceptable in medicine. People should also stop assuming that things will be fine. Anything can go wrong at any time. And also know your body. Know your body, know your system. Once you notice anything, seek help. It is better safe than sorry.
What issue I have with some second, third, mothers is like, oh, we've done it before,
All experiences are not the same.
Exactly.
Although me,
exactly.
I've done once, and that once it was twice.
Ajibola, you're smiling. I'm coming to you.
I've never been pregnant.
But you were a support system.
Support. So what she went through, I didn't.
You ran away.
I did not run away.
You were there now.
I don't want to share my experience, please.
So, I mean, it's good to always ensure that you seek help. Once, just know yourself. And like I said, no one experience is the same.
It's
that
the
you've done it
same
once
yeah.
does not mean that the second time nothing can go wrong. So
Okay.
it's important. Treat all pregnancies in their own unique way.
Okay.
It's
And
important.
one important thing that Abibola said this morning is the fact that the place of spiritual
Honestly,
is quite different
it
from
is.
medical.
Medical, right.
Please, don't come and say God will
God
deliver
will
me.
do it, oh,
We
no
have to
doubt
go.
about it. But you just need to do the needful, and then God will crown it.
Exactly.
Amen.
That's
Let's be realistic when we're spiritual.
Okay.
Yes, absolutely.
It's time to go.
It's time to go. We need to go. Thank you so much for watching the conversation. It's the Tuesday edition by God's grace. The midweek edition will be here at 10 tomorrow. Remember, also stay tuned. We will bring you live coverage from the APC Secretariat as events unfold much later on in the day. I am Abimbola Bello.
And I am Ajibola Ojashola. Thanks for watching the show.
And I am Adibimpe Omotayo. Stay safe, stay healthy.
You are watching Lagos Television, the voice of Lagos.
Ìròyìn orílẹ̀-èdè Nàìjíríà. Ọ̀gá àgbà àwọn ọmọ ogun orílẹ̀ wa Nàìjíríà pẹ̀lú gómìnà Ali àti ìpínlẹ̀ Benue àti ọ̀gá àwọn ọlọ́pàá ilẹ̀ wa ti ṣàbẹ̀wò sí Yewata pẹ̀lú ìlérí láti fòpin sí ìpakúpa tí wọ́n ń pa àwọn ènìyàn nífànàfànṣu níbẹ̀. Wọ́n ké sí àwọn èèyàn agbègbè ọ̀hún láti ṣàmúlò àwọn ẹ̀ṣọ́ aláàbò tó ṣeé fọkàn tán láti dojú ìjà kọ àwọn ọ̀daràn tó ń da agbègbè ọ̀hún láàmú. Àwọn ọlọ́pàá dìgbòlùjà ti fọwọ́ òfin mú àwọn afurasí 51 bẹ́ẹ̀ ni wọ́n gba àwọn nǹkan ìjà olóró kúrò ní ọwọ́ wọn nílùú Kano. Eléyìí ló wáyé lẹ́yìn ọjọ́ mẹ́ta tí àwọn ọlọ́pàá dìgbòlùjà náà ti ń rin àwọn agbègbè tó dàbí ẹni pé wọ́n fura sí káàkiri ní ìpínlẹ̀ Kano. Ìròyìn ìpínlẹ̀ Èkó. Ilé ìgbìmọ̀ aṣòfin ìpínlẹ̀ Èkó ti ké sí ọ̀gá àgbà àwọn ọlọ́pàá ní ìpínlẹ̀ Èkó àtàwọn míì lórí ọ̀rọ̀ àwọn ọmọ ẹlẹ́gbẹ́ òkùnkùn tí wọ́n fìjà pẹ́ẹ́ta ní agbègbè Mushin nínú èyí tí àwọn aláìmọ̀ọ́mẹsẹ̀ nínú ọ̀rọ̀ náà ti ṣòfò ẹ̀mí. Ọba Aláyéni Owólabí Adéníyì onísàbẹ̀ ti Ìgbòbí Ìsàbẹ̀ ti pè fún àlàáfíà lásìkò ìdìbò sáwọn ìjọba ìbílẹ̀ gbogbo nípínlẹ̀ Èkó pẹ̀lú ètò ààbò tó mọ́yán lórí láti lè ṣe ìdènà fún àwọn gógó oúnjẹ láwùjọ wa. Ìròyìn